much, sir. I think we'll go on to Praveen ma'am's talk now on stage 5 ROP.
Yeah, so I'll share with you the case of stage 5 ROP. So this is basically a case of premature twins. So they had a history of prematurity, born at 32 weeks, birth weight 1.2 kg and 1.1 kg, and they both presented with bilateral stage 5 ROP. So I did the surgery, and as we are familiar, the steps of surgery. I usually use an AC maintainer, then start the dissection after doing lensectomy. So just to keep it brief, what I'm trying to show is that as you do the dissection in this one twin, you can see I can easily remove all the fibrous tissue. I could go in, even clean up the funnel up to the disc. Peripheral cleaning was done, and you can see this is an open funnel configuration inside. It's okay. But if you see the second child, so this is how that first child had a very well attached retina and was fixating and following, and then slowly started recognizing toys and had some mobile vision. But if you see the second twin, so here again after lensectomy, I am cutting off the retrolental tissue, cutting the membranes, but you see the retina is just there. It's lying like a mass right behind the retrolental tissue. There are no planes, there is no funnel, there is no fold, there is no disc to see, and there is no peripheral trough. So this is the closed funnel configuration. So sometimes unless you go in, you do not know, and this child didn't do well. And basically why this happens is that the moment we know these are the principles, moment you have a break, this whole thing closes up, and this gives you a closed funnel configuration. So this is why the results of stage 5 ROP are also poor, and we need to give them a chance, and then only we will know which one will do well, which one won't. But sometimes things like corneal opacity, ectropion UV, posterior synecdoche, these can tell us that maybe there is an underlying break, and now they have been classified into stage 5B, and the results can be very dismal.
Thank you. Thank you so much, ma'am. Wonderful cases. So if I could just ask you, ma'am, now with the newer classification that we have of 5A, B, C, how often would you consider operating stage 5C?
So even before the classification, and probably that is why the classification changed, because we all had publications and we knew that patients with corneal opacity, ectropion UV, they don't do too well. So if you will give an anatomical outcome of 5 to 10%, these cases the anatomical outcome is so much lesser. You could try, and I think ma'am has also tried 2-stage, that you try to first clear the synecdoche and hope the cornea clears a little more and then do more. But then the results are very, very disappointing in those cases. Vis-a-vis these, the idea is not whether you will try surgery in those or not. My idea of bringing these cases is the take home should be that when these things are not present, you must try for surgery. In those cases, the outcome will not be 5%, it may be 30% actually. Even almost 1/3 of these cases, you will be able to reattach it.
And as far as the incisions for stage 5 go, ma'am, do you prefer limbal, iris root? How do you prefer?
Once I know it is stage 5 and I'm sacrificing the lens, then I go limbal.
Always go limbal. Right. Thank you, ma'am. Any questions from the audience? Any pointers from Subhadra ma'am?
So I was little curious that how they came up with the 5C, because the 5C in iCrop 3 it was not there before. Okay, now they just said those eyes with anterior segment involvement, and they've left it at that.
Yes.
Now my problem is, what do you mean by anterior segment involvement? Does it mean corneal scarring? Does it mean flat AC? Does it mean few posterior synecdoche? Does it mean a cataract? And do we have data to say that 5C, that is the anterior segment, is reflective of what is happening in the posterior segment? So I've been trying to collect my cases of 5C, operating them, and I can tell you that they are not always same. You can have posterior synecdoche and little bit of corneal lenticular adhesion, and yet the funnel may be quite easily opened like you did in the first case. And vice versa also, it may look like anti-segment is very normal. When you go inside, you see there's a lot of cholesterol, there's a lot of blood, and it's not as good. So I'm not really sure, first of all, what is the definition of 5C?
So
Should
I
we?
think it's only probability. So
No,
we
no,
had,
I'm just saying.
yeah.
So I think all of us, those who are doing surgeries, we should put 5A, 5B, 5C, what is there, but then put the descriptions also prospectively. And over 1 or 2 years, we will have enough data to say what is the relationship of anti-segment findings to the posterior segment findings. The reason for this is because we have shown by our basic science studies, which has already been published, that there is a subgroup of patients of ROP who have severe inflammation. They are inflammatory cells. And all this vitreous haze we talk about, we actually showed that these are actually microglia and they are actually, MMP9, and, there's an upregulation of the inflammatory component. Now, inflammatory component in vasculopathies, we have talked in CRVOs and in other PCVs, but we are not talking of the inflammatory component in ROP. So actually they have an inflammatory component. So whether that inflammatory component directly relates to the pathology in the retina is not clear. So I'm just saying that all of us, please note down the anti-segment findings, note down your intraoperative posterior segment findings, and we'll come up with the answer and we can tell the world how much of concordance is there and how much of discordance is there. Then we can say that, okay, this is the probability.
Yes, we had published almost 200 cases of stage 5, and this was a subset. That time 5C was not a classification, but we separately analyzed cases who had any interior segment findings like posterior synecdoche, corneal, mild corneal opacity, or flat AC, and they definitely did poorer as compared to those which didn't have. So it cannot be 1-to-1 ratio, but then the probability of the odds ratio of their doing well is much lesser as compared to
That will be
the other
there,
one.
but
Yes.
how much? I think that is what is important.
And the second, from the inflammation point of view, I think the formation of a retinal break triggers it. That
Yeah.
triggers the
So now
inflammation. So that could also be a
the
possibility.
reg RD component in setting of acute ROP stages has not been described. Again, we are recognizing these cases now. But mostly in ROP, when you talk of reg RD, they talk of late onset reg RDs, like at 10 years, 12 years, adolescence. But nobody is saying that acute phase, stage 4A, 4B, 5, can also have a reg RD component. They talk of tractional and exudative. So again, I think documenting those cases and saying that there is a reg component, that is the ones that I am doing the imbrication technique or alternate techniques or not do a vitrectomy. So they will worsen. And if you don't recognize it pre-operatively that there is a reg component, it's actually convex, it's not a concave which you expect, then you will make mistakes.
Thank
So
you,
let
ma'am.
us, describe these cases more in our files, then we can analyze the data prospectively.
Thank you so much, ma'am. So I think what we learned for ROP is basically it's a relatively easier surgery dissecting the tractional planes wherever you see them and not being too aggressive about it, and then letting the retina and the nature do its own course so that it goes back and gives this